My name is Martin Lee and I'm one of the Birmingham Orthopaedic Registrars. Here I have a focused presentation covering cubital tunnel syndrome, which refers to a compression neuropathy of the ulnar nerve at the level of the cubital tunnel. You can see on the diagram here, this is located posteriorly to the medial epicondyle. And in layman's terms, this is the funny bone that you may have hit before, causing the characteristic pain and paresthesia over both the palmar and dorsal surfaces of your little and ulnar half of your ring finger. There are a lot of ligaments, tendons, muscle, and bone around this area, all of which can contribute to this syndrome, but also repetitive elbow flexion in particular can worsen and aggravate these symptoms. The characteristic danger position for this is the one you'd use actually when you're driving. With this, you're propping your elbow on the windowsill, and in doing so, you're abducting your shoulder, you're flexing your elbow quite deeply, and you're gripping the steering wheel with your wrist in flexion, which all serve to increase pressure at the ulnar nerve. In terms of symptoms, the first symptoms people commonly report is paresthesia over the medial 1.5 digits in the hand on both the palmar and the dorsal surfaces. Later on, people may find a lot of wasting in the dorsal interossei in particular, as well as the small other intrinsics of the hand and the little finger, i.e. the hypothenar eminence as well, leading to clumsiness. It's worth noting the claw deformity you can get in severe cases in the ring and little fingers, and the ulnar paradox. To break this down, the ulnar paradox refers to a situation in which the clawing is actually worse in a low ulnar nerve lesion at the level of the wrist compared to a high ulnar nerve lesion at the level of the elbow. To break this down, in a low ulnar nerve lesion, the long finger flexors for the ring and little finger, which come from the elbow, are spared. These contribute to the appearance of the claw deformity. Therefore, if you only damage at the wrist, these long finger flexors are preserved and can worsen the clawing. In a high ulnar nerve lesion at the level of the elbow, however, these long finger flexors are also affected. Without them working, your clawing is actually less severe, hence the name ulnar nerve paradox. In terms of examination, always screen the neck and the wrist before moving on to the hand and the elbow in particular. It's worth bearing in mind that the ulnar nerve arises from the nerve roots C8 and T1, and if you remember from respiratory medicine, these can be invaded by a Pancoast tumour, so in someone with a strong family history of lung cancer or smoking, always offer to screen the chest. Starting with the hand, always assess the appearance for any wasting of dorsal interossei and of the hypothenar eminence, as well as any signs of clawing. From a sensory perspective, you want to test for 2-point discrimination at the level of the little and ring fingers, as well as test for muscle strength. There are a huge variety of tests you can do to assess the ulnar nerve, but the most famous is Froment's sign, which relies on adductopolysis. You ask the patient to hold a piece of paper like you would a key card, and you do the same on the other side of that paper. You play tug of war and you assess the patient's thumb position. Normally, your thumb is kept flat and adductopolysis is working to really squeeze that piece of paper. In someone with an ulnar nerve lesion where it's not working, instead the patient relies on flexor pollicis longus or FPL. In doing so, your thumb interphalangeal joint is flexed, and this is helping them to keep the card where it is. An FPL is derived by the anterior interosseous nerve from the median nerve, and that's not affected if you have an ulnar nerve lesion. Finally, look at the elbow. You can actually feel the ulnar nerve in the cubital tunnel because it's so superficial, and you can perform Tynor's tests like you would for carpal tunnel syndrome by percussing it, although this can be quite uncomfortable. You can even roll your finger over the ulnar nerve, and you can ask the patient to flex and extend their elbow and feel if this jumps or subluxes out of the cubital tunnel. In terms of investigations, history examination can be suggestive, but nerve conduction studies are usually ordered to confirm exactly where the compression site actually is. Ultrasound and MRI can be useful if there are other alternative differentials you're not sure about, and it's worth remembering that there are two very important diagnoses that can mimic an ulnar nerve compression, both of which are very serious. These are motor neuron disease and Guillain-Barré syndrome, especially if the patient paradoxically doesn't have any sensory symptoms and they're purely motor. Always be aware that those two are very, very serious differentials to have. And finally, don't forget a chest x-ray for a pancreas tumour if the family or smoking history demands this. From a management perspective, in a mild ulnar nerve cubital tunnel syndrome, in fact, conservative measures are usually pretty successful. Activity modification and avoiding repetitive elbow flexion with a elbow pad is usually pretty curative in mild cases. And usually these splints are worn around the clock and asking patients to avoid a lot of elbow deep flexion. In severe cases, the cubital tunnel can be decompressed with a long incision over the medial side of the elbow to divide anything tight that can be compressing the ulnar nerve at the elbow. And in severe cases where the nerve actually jumps or subluxes as the elbow moves, we can actually permanently move the nerve anteriorly away from the cubital tunnel to stop this jumping from happening. So to summarize, cubital tunnel syndrome is a compression neuropathy of the ulnar nerve at the cubital tunnel, and please be aware of these very serious differential diagnoses of pancreas tumour, motor neuron disease, and Guillain-Barré syndrome, especially if there aren't any sensory symptoms alongside it. Thank you.